is in the 60s, but now the incidence is increasing in the younger age.
Fine.
Less than 40 years, the
That's
incidence is increasing now. Yes.
right. Male, female.
And more in the male patients compared to female patients also. The incidence is increasing now.
Right. Altered bowel habits. Does it make
Yes,
any
the
sense?
altered bowel habits, that is one of the main history for a patient with colorectal cancer. And
Income.
that can
Next
either,
slide.
yes, incomplete evacuation of stools. The patient often feels feeling of fullness even after defecation.
So what
That
would that
is
indicate? What
the
would that
com
indicate?
yes, the common terminology for that is tenesmus.
What would
Uh,
that indicate? Where are you
uh,
suspecting the lesion?
this
High
is
up in the.
more commonly with proliferative growth in the lower rectum, sir, more than in the upper rectum. Uh,
Okay.
Common in the lower rectum. And associated with mucus and occasional blood-stained stools also indicate a proliferative growth, which overnight secretes the mucus and blood, which accumulates proximal to the growth.
How would you
So,
differentiate it from, bleeding from, for example, hemorrhoids or fissure? Looking at
sir,
the history.
fissure first, it will be painful. It won't be painless. And this in hemorrhoids also, the blood, the patient will give history of blood splashing in the pan. It's so commonly after the defecation the bleeding
So
happens,
that's
and that is also painless. Yes.
okay. And loss of weight is going to be
Yes,
important.
sir. History of loss of weight is important in this case. Yes.
Addiction.
Addiction, yes, sir. Cigarette smoking, tobacco consumption are one of the risk factors, environmental risk factors for colorectal cancer, and he doesn't have any history. Alcohol occasionally, but it doesn't seem significant. And
Mm,
mixed diet,
diet.
we also, yes, mixed diet, we also want to ask whether increased high red meat consumption or increased intake of saturated fats.
Let's move on. Yeah,
And
sorry.
yes,
Fine. Next slide.
Any other relevant history that you would like to ask?
yes, sir. I would like to ask for family history of malignancy or any in the person also previous history of polyps,
Right.
any procedure for that, and family
Mm,
history of
so,
polyps or colorectal cancer. Yes.
so what is that? What are the chances of having a family history percentage, and what kinds of family history you are kind of aware of? Familial, syndromes which can be
Yes.
relevant.
Yes, sir. Uh, a person with a first degree relative of with any history of polyp or cancer, there's a 2 to 3 fold increased risk of colorectal cancer in that individual. And we'll want to look at the first degree relative history, and risk also increases if it is of a younger onset in that person. Um, and
Any hereditary syndrome? No.
Yes, sir. The most common is Lynch syndrome, that is accounting for 3% of all colorectal cancers. Next
What
common
is it?
would be Lynch syndrome is due to it's a hereditary syndrome due to a defect in the genes necessary for mismatch repair. So
Right.
that is the most common syndrome. It is an autosomal dominant inheritance, and there are four genes which are involved, sir. MLH1, MSH2, MSH6, and TMS2. The risk for colorectal cancer is highest with MLH1 and MSH2 compared to the other genes.
And Snigdha, what other cancers one can have with Lynch syndrome?
In males, also other cancers may be gastric cancer, upper tract urinary cancers, and in females, it is endometrial cancer is the most common cancer associated with Lynch syndrome. So, other than Lynch, also there are other polyposis syndromes which may also be associated with colorectal cancers, like AFP, Pierce sugar polyposis.
Let me correct you, Dr. Snigdha. Even in
Yes,
females, colorectal cancer is still the number
yes,
one cancer disease.
yes,
The most common extracolonic cancer, as you
extracolonic.
said, is the endometrium.
Yes, sir. So, most colon, extra colon. And a personal
So,
history of
and
previous.
apart from Pew Ziggers, did you mention anything else? I didn't quite catch you.
Yes, sir. I mentioned that other polyposis syndromes like APC and
APC is the
Haman.
gene. APC is
Uh,
the gene, but what is the syndrome called? FAP,
familial
familial,
adenomatous polyposis, sir, and also attenuated familial adenomatous polyposis, and also hematemesis syndromes like pure sugar polyposis are also associated with colorectal cancers.
can inflammatory bowel disease be a predisposing factor?
Yes, sir. Inflammatory bowel disease like ulcerative colitis and Crohn's disease, a long-standing history of IBD of around 10 years is associated with an increased risk of colon cancer.
So yeah, 10 years would be 5%, 20 years would be 20%. So more than 25 years can be as high as 40%. Fine. So personal history of, you have mentioned that, I think Rasagna has mentioned that the patient had polypectomies in the past. So that's important. Okay.
Dr. Snigdha, at this point, just to highlight, what's the approximate age-adjusted incidence of colorectal cancers in men in India? Any stats that you can give us?
In India, the average is slightly lesser than the global average, sir. The average is around
About 4
50.
to 6 men for every 100,000, and about 4 to 5 women for every 100,000 are likely to develop colorectal cancers. Because we are dealing with a younger individual, this thought would be relevant to ask that.
Yeah. So female would be slightly less, male would be slightly more. It's about 3:2. And what's the percentage of having a colorectal cancer if somebody has got FAP?
It's
And at what age?
100% incidence by the age of 39 to 40 years.
And attenuated FAP?
The age onset is a little late than classic FAP, and incidence is also around 75 to 80% in the.
Okay, can we move on?
On examination, this is a middle-aged male who's well-built and well-nourished. He's conscious, oriented. His Eastern Cooperative Oncology Group, he's 1. General physical examination is quite normal. Abdominal examination is soft, non-distended, no palpable mass or organomegaly. Grossly normal examination. Anything particular, Dr. Rasagna, that you'd like to look for in the abdominal examination when you have heard the history of, altered bowel habits?
We
Monoplus,
want to look for any, yes, abdominal distension, maybe rule out obstruction in some cases. Other than that,
Anything else? It's all mentioned there.
Any palpable lumps so.
hepatomegaly.
Yeah, and sometimes you also
Yeah, if you have a big colonic mass, sometimes you can feel it. Rectal, obviously, not be able to feel it, but right colonic, sometimes left colonic, they can be palpable if it's big.
Yes.
And sometimes you can also get a palpable sigmoid colon, which is loaded with stools in the left lower quadrant. Especially if there are obstructive symptoms, but not frank acute obstruction, you can get in left-sided rectal growths. What's the next thing that you'd like to do, Dr. Rasagna?
Next, I would like to proceed with the digital rectal examination.
Excellent. So can you tell us what you'd like to look for in the digital rectal examination?
Even before that, just very basic, how do you do a digital rectal examination? Because if you're doing a colorectal clinic, this is bread and butter. So you need to know the position, how to examine the patient.
Yes.
So can you just
First,
briefly
after informing the patient about the procedure, the position will be a left lateral position or the Sims position, with the patient turned onto the left side, and the left lower limb is extended, and the right knee is flexed and up to the abdomen. Right hip and the knee are flexed.
The other option, other possibility is not the Sims position, but both the knees flexed. And that will actually give you a better access to the buttock, when you're looking, especially with the rigid sigmoidoscope. And the table should be as high as possible, and the buttock should be overhanging the edge of the bed.
To the edge, yes.
And you have to sit on a stool next to the patient, and then you can have a good access. Good illumination is important. And then what do you do after you have positioned the patient?
And then, yes, so first is the inspection of the perianal and the anal region to look for any growth protruding out, or to look for any skin changes, that is fistula, or any mucoid discharge. Those are the inspection. And then we'll have to go ahead with palpation after lubrication. Gentle per-rectal examination, first along the pulp faces posteriorly, and then we enter the anal canal. and feel circumferentially around for the tumor. If anything is palpable, we'll want to know the distance of the tumor, that lower border distance from the anal verge, whether it is circumferential or what is the exact position according to the clock position, and whether we can palpate the upper border of the tumor or not, and if it is freely mobile or if it is any restricted mobility. And also its a relation, mobility anteriorly, posteriorly, and all around.
Anything else what you feel?
And also like
And anal tone, yeah. Anal tone we'll have to assess. Yes.
Sphincter tone,
Sphincter
yes.
tone. Yes.
Sometimes if it's an advanced disease, what else can you feel?
Advanced disease,
Tumor might be
they say
higher up.
yes, we can feel mesorectal nodes. That is what it is described, but I have not.
You
Tumor cell,
mentioned the extent of the tumor from the anal verge,
Anal
right?
verge.
Anything
Yes.
else that you would specifically like to look at? Extent of the lower
Yes,
end of
extent
tumor?
of the lower end to the anorectal ring also, and also
Very
to
good.
the anal verge.
How
Yes.
would you, Dr. Snigdha, palpate the PR sling? How would you find out?
the verge is usually felt as a groove about 2 centimeters from the anal verge. So,
Is there any maneuver that you can do to enhance the anorectal ring? The palpating digital finger, you can ask the patient to hold tightly or to cough, and then you can actually feel, especially posteriorly, a nice groove. Anything else on inspection that you'd like to see specifically? Any former scars, any hemorrhoidectomy that's been done in the past? Many people have these things apart from what you said. And you can also assess the sphincter tone by looking at the perianal winkle. You can ask them to
Yes.
contract the corrugate rani. All these things give sort of a functional assessment of the tone.
Yes.
Just in the interest of time, to summarize, like you said, we have the character of the lesion, whether it is ulceroproliferative growth or ulcer or stricture. In him, it was a UPG. The lower extent was about 7 centimeters from anal verge and 4 centimeters from the PR sling. The upper extent was not felt. Again, that's important to know. Dr. Snigdha, why would you specifically document whether we can feel the upper extent or not in the context of rectal cancer?
It will give us an idea of where the tumor might have originated from, so like upper, mid, or lower rectal tumors, and also the longitudinal extent of the tumor can be known by examining the upper extent.
Anything else in specific to rectal cancer, the therapeutic options and implications?
why is it important
Yes,
to
sir.
know the approximate?
We can know if it's a rectal cancer or exclusively a rectal or a higher up cancer.
Has it got anything to do with response assessment?
Sorry, sir.
Will it help with assessing the response to whatever treatment you're planning?
Yes, sir. The exact location of the tumor will have a lot of treatment implications, sir. And
Like what?
Like if it's a rectosigmoid growth, or if it's above the peritoneal reflection, or if it's below the peritoneal reflection.
What would be the
Then
difference in management then?
mainly tumors which are above the peritoneal reflection are treated more like colonic malignancies, and we would go with upfront surgery, sir. Whereas those below the uh, peritoneal reflections would require some kind of neoadjuvant therapy as standards.
That is not a decision that we are going to take on just a
Yeah.
rectal
Rectal
the
examination.
relation to the peritoneal, not
Yes.
not know just whether it. Anyway, that's fine. On to the next findings.
Wall involvement based on clock position. His was a circumferential growth. There was restricted mobility, mild luminal compromise, prostate not involved. Sphincter involvement, there was an adequate resting tone as well as an adequate squeeze pressure. So these are his digital rectal examination findings. Mesorectal nodes, inguinal nodes, there were no nodes palpable. With this, Dr. Snigdha, can you tell us your clinical diagnosis?
Yes, sir. Going by the history and the clinical examination findings, I would give my first diagnosis would be a malignancy of the rectum, sir. Rectal malignancy. And I think I would keep it only as a malignancy, sir. I have ruled out benign causes because of considering the symptoms of weight loss, short duration of onset, and the ulceroproliferative growth, which is palpable. So I would keep only malignancy as my diagnosis.
Okay. And what would be the histopathology for rectal cancer, mid, upper rectum, or even lower rectum? Histopathology.
Most probably adenocarcinoma.
If it had
So
been
what
lower
would
rectum,
you do next?
anorectum, would have been something different.
No, so
Will it
only
be-
if it was at the anal canal or much more lower down, I would maybe suspect a squamous cell. But otherwise, for upper mid and lower rectal also, I would think of adenocarcinoma only.
Okay.
What would
How
you
would
do
you proceed
next?
from here?
I would like to proceed with investigation, sir. I would like to do a rigid proctoscopy along with a biopsy, and then I would like to go ahead with blood labs and imaging, sir. So,
So, in the bloods, what exactly?
besides the routine investigations like CBC and biochem, I would like to go ahead with tumor markers CEA and CA19-9.
Anything else you would do? You've done a biopsy with a rigid sigmoidoscopy, serum CA, you've done imaging, anything else?
Yes, sir. Ideally, all patients, if the biopsy comes as malignant, all newly diagnosed cases should undergo MSI testing on the
No, before that.
biopsy also, sir.
For that, especially in this patient, 42 years old.
Colonoscopy, sorry, sir. I would do a colonoscopy.
What
I would do,
colonoscopy?
I would do a flexible colonoscopy to see, and if possible, a complete colonoscopy up to the ileum to see for any the presence of any polyps or any synchronous growths.
Why would you not want to do a colonoscopy?
If it's a near obstructing growths, then
So, in this patient, you are expecting that you're going to do a full colonoscopy. In this patient,
yes, so even though it is a ulceroproliferative growth, he's not giving any obstructive symptoms, and the finger could be passed like.
okay, right. So, let's move on.
Yes.
So, what sort of imaging would you do? You've done a colonoscopy, the biopsy has come as well-defined adenocarcinoma, MSI stable, CA is about 5 point something. What imaging would you want?
First, I would like to do a CT scan, sir, CT of the thorax and abdomen, and then for local staging, I would like to do a MRI pelvis, sir. If the CT is non-metastatic, I would like to do an MRI pelvis for locoregional staging.
You do a contrast MRI or a plain MRI?
A plain MRI is sufficient, sir.
Now, you were mentioning you would do an MSI test. Why
Yes,
would
sir.
you want to do an MSI testing? Is that what you would do, or would you do something else? And would you want to do it now or later?
Ideally, we should do it on the biopsy sample, sir. So because it has some treatment implications. Because
That's the reason why you would do on a biopsy sample. So what are the options? You can either do it on the biopsy sample or you can do it on the resected space.
yes, sir.
Are there any recommendations, or which would you prefer?
The NCCN now recommends testing it on the biopsy itself, sir, because for if they come to be MSI high, now it has said that we can use immunotherapy also in the neoadjuvant setting.
Yeah, so that is as far as treatment implications are. More
Yes.
practically,
Prognostically,
things are more fixed in a biopsy specimen rather than in a surgical specimen.
Yes, sir.
The reason why most pathologists prefer to do biopsy specimen. Next question
if you
is there any alternative to MSI that you would consider?
Sorry, sir, alternate?
Alternative to MSI testing that you would consider? Dr. Rasagna,
We do
Sir,
IHC.
IHC for MMR proteins.
which would you prefer?
The first IHC, it is easily available for MMR.
So don't straight away jump on to MSI. IHC is a very easily done investigation.
Yes,
The
sir.
pathologist can do it in the lab. The reports will be available pretty soon.
Yes, sir.
It is always preferable to do IHC MMR. In fact, even the ESMO recommends that the first line of testing, the mismatch repair gene, or right?
Yes.
You were
Yes.
talking about MSI. Can you tell me what is MSI?
MSI is microsatellite instability, sir.
What
There
do you mean by that?
are microsatellites are short tandem sequences present in the DNA. And these microsatellites are more prone to errors
Is there
because
any other word or term you need to use? Short tandem sequences? Anything else?
of short 1 to 3 nucleotides usually,
No, they're short tandem
uh,
repetitive sequences.
repetitive sequences.
That is the
Yes.
catchword.
Yes.
All right.
And they're more prone to damage. And they're not always, they are repaired if the mismatch repair gene system is intact. But in case of deficient MMR status, and that repair is not possible. So that leads to accumulation of the errors and then DNA damage.
Why would you want to do this here?
So one prognostication, it has a better prognostic factor, MSI high tumors, and it has implications in the treatment, either neoadjuvant or adjuvant uh,
Anything
treatment
One is
else?
more chemo.
implications.
And this
Which one is more
patient
chemosensitive?
In this patient, MSI high will indicate hereditary predisposition.
always
Not always, we'll have to confirm with the germline mutation testing. If
only indicates a possibility of a hereditary cancer. Does it
yes, sir.
necessarily mean that it is hereditary?
No, it doesn't mean we have to first see which MMR proteins is deficient on the IHC. And if MLH1 is not expressed, we'll have to go ahead with the other testing like a BRAF mutation. If that is present, it mostly indicates a sporadic cancer. If not, then we go ahead with the germline mutation and then confirm on germline mutation and then say it is a Lynn syndrome. Till then, we can't call it as a hereditary.
Always do MRI. So,
Yes,
always. So if you
yes,
find a
sir.
tumor which is fixed, everywhere,
Yes.
will that make a huge difference in doing an next MRI? If the
First
tumor is
MRI,
totally fixed, like a frozen pelvis, fixed tumor, would
yes.
MRI be always indicated or you can skip it?
So we'll want to do an MRI because we want to compare it to the post-treatment response if possible. But
Investigation of choice in a rectal cancer for local staging would be.
MRI pelvis. Yes.
Dr. Bharat, can you tell
Yes,
us?
sir. So, any other anal manometry, would you consider doing that in all patients or in select cases? Dr. Rasagna?
Yes, not in all patients, sir. In select cases where we are planning on intrasphincter preservation and we're not clinically sure of the anal tone. So we'll want to confirm with the anal manometry if it is available.
It's good now,
Mm.
apart from oncological outcomes, to look at functional outcomes and quality of life issues, especially if you're dealing with multiparous women, very lax pelvic floors. It's good to get a baseline anal manometry, provided the anorectal junction is not involved. If it's a tumor where the anorectal junction is involved, anal manometry is moot. So colonoscopy, he tolerated the bowel preparation well. Again, that's a small rider to say that he had no obstructive symptoms. The Boston bowel preparation score was 2. Rectum showed a proliferative growth with mild luminal narrowing. It's about 6 centimeters from anal verge, extending up to 10 centimeters, negotiated with mild difficulty, no other polyps or lesions, and they achieved ileal cannulation. I think this is just to highlight that ileal cannulation is essential to document, to say that the cecum has been visualized, appendicular orifice has been visualized. It's important to note the bowel preparation score. It's important to note the how he tolerated the bowel preparation. All these are small clues to our symptomatology. Like Sir said, it was well differentiated adenocarcinoma, MSI stable. We'll just now run through the radiological investigation of choice. Like you all said, for local staging is a dynamic MRI pelvis. Let's see. So I hope this is visible. I'm going to run the T2 SAG sections. That's the growth. Can you comment on it, Dr. Snigdha or Dr. Asagna? I will show all the.
Before that, can you tell me what sequences of the MRI are going to be used?
T2 weighted MRI sequence is the preferred sequencer.
What views?
All axial, coronal, and sagittal. Axial and coronal has to be taken in an oblique plane related to the anal canal.
Any other sequence?
T2 weighted image, and then post treatment we'll also want a diffusion weighted imaging.
Which is the first image that you would look at? First sequence you would look.
First sequence.
First, I would see the
How
sagittal.
would you look at it? Tell me how you would look at it.
First, I would see the T2 weighted sagittal, sir, to see for the location of the tumor.
What else will the sagittal image tell?
The sagittal will give us the location of the tumor, its anterior and posterior relations. And
Will it give the anterior and posterior relations? Sagittal? You
no,
already
sir.
mentioned something earlier.
Yes, sir. I mean, its relationship to the peritoneal reflection also.
Yes.
And
What do you see
anything
here?
else?
Sorry, sir.
Anything else? What else will it tell you?
Its relationship to the peritoneal reflection and its relationship to the presacral fascia also.
And the distance from the anal verge and
The distance from the anal verge. Yes.
Anything in the mesorectum?
Yes, sir. But mesorectum we would see it better in the actual image, sir. Regarding the MRF involvement and the mesorectal nodes and all would be better seen in the actual image.
Where do you see the tumor here?
Sir? Sorry,
Where
sir.
do you see the tumor here?
Can you see the tumor? And where about? In relation to the
Yes, sir.
sacrum?
Yes, sir. It is a almost a mid-rectal tumor, sir.
This is relation to the peritoneal reflection.
Peritoneal reflection seems to be free, sir. It's not in.
Dr. Snigdha,
Yes.
we mentioned earlier that there were rectosigmoid is treated more like colon and prognosis. On an MRI pelvis, how would you define what is the rectum?
So on the MRI, an imaginary line drawn from the top of the pubic symphysis to the sacral promontory is the boundary, sir. Below that, we consider it as the rectum, and above that, usually we consider it as the rectosigmoid of the.
So this
There's
tumor
a change
is
in thinking nowadays. Rather than that line, the
Hmm.
radiologists rely more on the takeoff of the mesocolon. They rely more on that to identify the rectum.
Okay, sir.
so in this particular case, where exactly is the tumor? I can show some more cuts here.
What would you look for in a coronal section? What the information that give you?
In the
Coronal section.
Sorry.
Yeah. Prasad
In
Nagar.
the coronal section, if it is a middle or a lower rectal tumor, more for the lower rectal tumor, we want to know the relationship between the tumor and the sphincter, internal sphincter, intersphincter space, and the external sphincter
It's
involved.
more useful for low rectal tumors, especially very low rectal tumors.
Yes.
This is the next image. Axial.
Anything that you see in addition to what you have mentioned?
Yes, sir. There's one mesorectal lymph node, and the size in this other image they mentioned is 7.4 millimeter.
Location, anterior, posterior, lateral,
Location, anterior and lateral, right, left lateral.
left lateral.
There are, it's almost near circumferential in certain areas. Can you also notice something else that has been given in this patient? You can see that white thing that is filling up the rectal lumen. Is that rectal contrast? Is it recommended routinely to do rectal contrast, or
No, so rectal contrast is not routinely recommended.
it's not routinely recommended? Here you
No.
can see that there is rectal
Yes.
contrast that's given, but it's not
Yes.
routinely recommended to give rectal contrast.
Yes.
Now, based on these findings, will you be able to tell us the rough MRI stage? Any of
Yes.
you? Just take a guess. So how confident are you in reading a rectal?
Sir, in this section, it looks like the tumor is invading through the subserosa into the mesorectum. So I'm thinking T3 and
Subserosa,
mesorectal.
is there a serosa below the petal?
No, I meant beyond the bowel wall into the mesorectum.
Rectal fat.
Yes. Yes.
Fat.
So T3, what? A, B, C, D.
Sir, yeah, I think B, I'm not sure.
It's tough to
That's
say,
why
but
you need
can
to
you just
measure
tell
up
us
to know it.
theoretically what are the subclassifications? What is T3A?
T3A, again, it depends on the distance of invasion into the perirectal tissue. If it is less than equal to 1 millimeter, it is T3A. 1 to 5 is T3B. 5 to 15 is T3C. And more than 15 millimeters is T3D.
Between the
prognostic
anterior and
implication of
posterior mesorectum, which is thinner?
Anterior mesorectum is thinner.
So apart from the distance beyond the rectal wall, also the distance from the mesorectal fascia is crucial in decision making.
Yes.
What
At
is the
this-
prognostic implication of subclassification of the?
Prognostic T3A and 3B are considered early rectal cancers and they behave better than T3C and T3D, sir.
Not
And
considered early, they are considered prognostically equivalent to early.
yes. And the treatment also for T3A and B, we can consider upfront surgery.
So you have
Whereas
mentioned the T stage. What about the
Yes.
N stage? If you think it is likely to be?
Yes, sir. There's one mesorectal node that I can see, and the size is 7.4, and it's a little irregular. I'm thinking it is involved, and it will be N1 based on this.
Okay. Dr. Snigdha, any other points that you would like to see in the MRI report or you would see for yourself?
I'd like to see if there's any MRF involvement and any presence of any EMVI, sir, and also look for the presence of any lateral nodes. I think in
Anything
this
else?
case,
Mentioned
uh,
everything. One more thing. Something as important as EMVI, tumor
EMVI
deposits.
is a tumor.
Okay.
Yes.
So in this cut, can you make out anything? Relation
There
to
are
MRF?
there are no lateral nodes, sir. I think MRF is threatened anteriorly at um, 1 o'clock around, and I think there is EMVI at 3 o'clock.
So what do you
Sir.
see at 1 o'clock? What is that thing anterior?
It anteriorly it seems close to the MRF, so the tumor.
So you wouldn't really
Close,
call
or
that
is it?
MRF because MRF is below the peritoneal reflection. This cut, axial cut, what
Yes.
you're seeing anteriorly is actually
It's
the
above.
peritoneal reflection.
Yes, sir. Yes.
And this is the typical beak sign. Okay,
Yes.
that indicates whether it is a T4A or not. That is whether the serosa of the peritonealized rectum is involved.
Yes.
You can just stop at that exact point, find that the beak sign is not interrupted, which means it is not a T4A.
Okay.
And also see EMVI, probably no tumor deposits. There you have the final stage, T3C N1, MR T3C N1, MRF threatened, Written no EMBI, but I think there is an EMBI. Right.
Next.
CEA was 5.3. At this point, CT thorax was negative for metastasis. So your clinical diagnosis, Dr. Snigdha?
My clinical diagnosis is the patient is a case of carcinoma mid rectum stage. Clinical stage is CT3N1 and well-differentiated adenocarcinoma. And he's a secretor with raised CE.
Your diagnosis is incomplete.
With no obstructive symptoms and no involvement of the anal sphincter compartment.
No. Something more important that is going to influence your
MRF,
management. You have to tell the complete MRI findings. The location, the T stage, the N stage, relation to the MRF, presence or absence of EMBI or tumor deposits, or lateral pelvic nodes. And in the lower rectal tumor, you also need to say what is the relationship of this tumor to the levators and to the sphincter compartment. Then your diagnosis will become stage of rectal cancer.
So the patient is a 42-year-old male, sir.
No, that's fine. So now you have this in front of you.
Yes.
Is that all you need, or anything else, or you will straight away proceed to management?
I'll proceed to manage.
How would you do that?
So the case is a 42-year-old male with locally advanced rectal cancer, sir, T3N1 with threatened CRM with possible EMVI also. So I would like to proceed by first planning him for neoadjuvant therapies.
Would you take that decision on your own?
No, sir. Sorry, I would discuss the case in my joint clinic.
Just tell what you would normally do.
Yes, sir.
You wouldn't dream of treating this patient without discussing it in an MDT.
Yes, sir. No, sir.
That's very important. Why is it important? Keep saying MDT, MDT.
Yes, sir.
Is there any evidence to say that discussing an MDT will improve the outcome? Are you aware or not?
No, sir, I'm not aware.
There is evidence. There is evidence. There are at least 2 studies which show that discussing rectal cancer in an MDT is relation to the mesorectal fascia and planning the treatment and bring down the positive CRO.
Okay. Yes.
In this patient, we said there was a threatened MRF. What exactly is a threatened MRF, Dr. Snigdha?
On a MRI, a threatened MRF is defined as being less than 1 mm. Sir. That is the distance between the most advancing edge of the tumor and the non-peritonealized surface of the rectum in this case.
Is it only tumor? Is it only tumor? Can it be node also?
Or a node, sir, or a suspicious mesorectal node. Distance between the mesorectal node and the non-peritoneal or mesorectal fascia.
So what difference does it make? You have less than 1 millimeter and more than 1 millimeter. What is the difference in survival, local control?
A positive MRF in the as shown in the MRI is also associated with higher rates of CRM positivity post resection also, sir. So and a positive CRM is associated with higher locoregional recurrence.
All right. What would you do here? You discuss in the MDT. Who are leading the MDT, and if someone asks your opinion, what would you say?
So as this is a locally advanced CA rectum, I would like to give some kind of neoadjuvant therapy, sir.
First, tell me, what is going to be your intent of treatment?
Sorry, sir?
What is going to be your intent of treatment? Curative or palliative?
No, so my intent, as this patient has no distant metastasis, and the intent will be curative only, sir.
The
So
next
what-
thing you need to see is whether this patient just requires surgery or would you want to do something.
You mentioned about neoadjuvant. So what
Yes.
neoadjuvant would you consider? What are the options?
Usually there are multiple options, sir, considering this case, which is a case of mid-rectal tumor, and it has a threatened MRF with EMVI. Usually, in our institution, we usually give long course chemoradiation and then reassess the response. So I would like to go ahead with the long course chemoradiation followed by response assessment.
What is the
Is
idea
it-
of doing that?
Neoadjuvant therapy in the form of radiation has shown to reduce the local recurrence rates. Primarily, the failure of a rectal CA rectum had been a local failure, loco-regional failure. So the idea of giving neoadjuvant radiation has been to, studies have shown to reduce the local regional recurrence rates. That's
In
why
this particular patient, why would you
Yes.
want to give radiation? This
Uh,
patient, what is the reason for giving it?
locally,
You said it yourself.
yes, sir.
Locally advanced is not enough.
She has a threatened MRF, CRM, sir. And
What do you
also,
expect after radiation for a threatened MRF?
radiation has been associated with margin sterilization also, sir. And
We are hoping for a margin negative resection if you
Yes.
give a neoadjuvant radiation.
yes, sir.
What
Mhm.
sort of radiation will you do?
Long course is one option, yes. Any other option that you have? Or
Yes,
is always
other option would be short course radiation, sir.
which one would you prefer and why?
I would prefer long course radiation, sir, over short course radiation.
Are you aware of any comparison between the two?
Yes, sir. Most of the TNT trials have in the standard arm has always been long course radiation, but
No, I'm not talking about TNT trial.
yes, sir. Also the Polish 1 trial was also a comparison between short course radiation and long course radiation, which did not show any difference between DFS or OS.
Any other trials?
And the Stockholm trial also.
Stockholm 3.
What is Stockholm 2 trial? What does it show?
Stockholm 2, I'm not aware.
So do any of these trials show any improved local control or survival when you give long course when compared to short course?
Or
No,
sphincter
sir.
preservation or anything?
No, sir. No trial has shown benefit of either one modality over the other in terms of either survival or sphincter preservation.
So,
Okay, so
how long?
you have-
Please go on, sir.
Sorry, carry on.
You have given long course radiation. You will give chemo
What-
radiation, right?
Yes, sir. Chemoradiation.
Or those
Why chemoradiation and not just radiation?
The chemotherapy is used to, as a radiosensitizer, sir, which will enhance the effect
What-
of the radiation.
So what do you use for chemotherapy?
We use either 5-fluorouracil or capecitabine, sir.
And when do you want to reassess this patient after long course?
After at around 6 to 8 weeks, sir, after the long course radiation.
How do you reassess?
I would reassess with a digital rectal examination, with a proctoscopy done before, and with a MRI pelvis.
Anything else? Proctoscopy you said and MRI and clinical
Yes.
examination.
Yes.
Right.
Dr. Rasagna,
Want to-
any other strategies for neoadjuvant therapy? Dr. Snigdha has talked about long course chemo RT, probably 50 grays or 50.4, 45 plus 5.4 dosed. with sensitizing doses of capecitabine. Apart from this, any other strategies that are there? If we are looking at bulky extramesorectal nodes, bulky mesorectal nodal disease, EMVI positivity,
Yes, sir.
anything
There are
else?
options where a neoadjuvant radiation, either short course or long course, followed by neoadjuvant chemotherapy is coming up now, and then followed by surgery.
What is that called?
Sir, total neoadjuvant therapy, and it is for 42-year-old young male for bulky local tumor T4 N2 EMVI positive MRF threatened. Total neoadjuvant therapy may be given in such cases.
So can you move on to the next slide because we have one more case after this, I think.
Yes. So this patient received long course chemo-RT, along with that followed by 4 cycles of capecitabine oxaliplatin-based neoadjuvant therapy like the TNT approach. What instructions would you advise following completion of neoadjuvant treatment? Is there anything specific that you'd like to tell them? At what, how many weeks after your radiation do you normally assess patients for
Yes,
response?
she has said I think 6 to 8
After
weeks.
yes, after 6 weeks, sir.
6 weeks. Are there anything now saying that waiting longer improves PCR rates?
Yes, so waiting longer can improve PCR rates, but there's also evidence that says if the surgery is delayed more than maybe 10 weeks or 11 weeks,
Hmm.
then that also has a adverse prognostication on the.
So when would you wait and when would you not wait? The 6 to 8 weeks, you
Sir,
see the
after
patient.
6 weeks, yes, after 6 weeks, clinically, if we think the patient is responding well, and on MRI also, if there are features of near complete response, then we can give the option of waiting for longer period to see if patient will achieve a complete clinical response or not.
So it's
The
like
chances of complete clinical response after TNT.
Yes.
What are the chances of
Sir,
complete clinical response? Is it more with mid upper rectum or lower rectum? What sort of tumor?
now
Mucinous,
PCR rates are
well
almost
differentiated.
25. Yes, PCR rates now are almost 25 to 30% in some trials, sir. And mucinous do not really respond to chemo that well. So that's one of why it doesn't respond to chemo. So we don't expect for that mucinous tumor to have a complete clinical response.
Okay, let's move on.
Can we go on to the MRI after treatment?
Let's move on. Yeah. I think we have covered all this. Okay, so that's the response now. What do you see compared to the previous
Can you just
MRI that you saw?
tell us the
Yes.
report?
The major difference that you see.
Bharat, can you just tell us the report?
Yes, there has been a really good response that you can see. And they say MRTRG 1 bar 2. There's no pelvic sidewall disease, no significant mesorectal nodes, a lot of post-radiation changes that are present. It looks like a hypointense circumferential wall thickening in the upper and mid rectum, probably like a fibrotic scar. Do a colonoscopy. This is the evidence of how it looked before and now. There is some telangiectasia. There's probably query residual lesion at 7 centimeters from anal verge. CEA repeat is 3.9. It's come down marginally. What would you like to do next?
Sir, MRI showing post fibrotic changes, but on colonoscopy there is doubtful residual disease because there is mucosal irregularity and telangiectasia. So I would like to proceed with surgery for this patient.
You want a biopsy documentation or would you do surgery anyway?
Sir, if you're thinking there's a residual lesion, then biopsy is not really necessary before surgery.
Even if there's a complete response, would you want to do a biopsy?
If
Why
there
did
is
you
complete
qualify
response,
saying that if thinking in terms of residual disease, you will not? Does that mean that if there is no residual disease,
Would you not do a biopsy there?
in complete clinical response is also biopsy is not
there is
mandatory.
no role for a biopsy at all?
No role, only clinical, MRI wise and colonoscopic
So what surgery would you plan here?
proctoscopic. Sir, it's a mid-rectal tumor, so I would like to go ahead with low anterior resection for this patient.
So after you have operated, what are the things that you would want to see in the pathology?
Pathology report first, on table, we want to see for the adequacy of the TME. And in the pathology report, again,
How do you
histology.
determine the adequacy of the TME?
Sir,
What is that? How would you describe it?
It
Looking
is
at the
described
specimen.
as yes, yes. The specimen should be covered with a shiny layer.
That's
It should
fine.
be a
How do
bilock.
you,
Yes,
what term would you give if you have done a
it's a
good TME?
complete, yes, complete TME.
Right. Anything else? What are the other things you would want to know?
Other things, whether CRM is negative and presence of positive pathological mesorectal nodes and proximal and distal margins, PNI, LVI. Yes.
This is
All
YPT3
negative.
and 0.
Yes.
Any subsequent treatment will you plan?
Yes, so because patient has received 4 cycles of neoadjuvant chemotherapy, I would like to complete 6 months of total adjuvant chemotherapy too in this patient.
How would you follow up this patient?
It's T3N0, so it is stage 2, and it's first every 3 monthly visits for the first 2 years, followed by 6 monthly visits for the next 5 years, sir. And every visit, history and physical examination with serum CEA level measurement. And CT is recommended every 6 months for stage 2 and 3 patients.
What are you worried about? Your 42-year-old male who you have done a low anterior resection. He's
Yes.
come to you every 3 months. How are you
Yes.
going to evaluate him in the OPD?
One for the oncological recurrence, like local recurrence, and also for quality of life, we have to ask for the bowel habits, the number of number of times that is defecating, or the
Any specific
uh,
score that you'd like to calculate here?
yes, so there's something called low anterior resection score,
What do
where
they?
based on
What?
5 aspects, yes, based on 5 aspects, whether they have incontinence for flatus or incontinence for liquid stools, and based on the uh, number of times that they are passing stools in the day. And there are two other components, and they're divided into mild and severe, mild, moderate, severe. And based on that, we can categorize and treat accordingly.
Should we move on to the next case, sir?
You have time?
We have time.
Yes, sir, we have 10 minutes.
Okay. Just want to clarify that regarding the biopsy on when you are re-examining the patient. If you
Yes.
suspect a small residual disease, you will do a biopsy because you need to document whether there is a residual disease at all. But when there's a
Yes.
complete response, the mucosa looks healthy, obviously don't do a biopsy. But if you
Yes.
say I will not do biopsy at all, I'll go by my clinical judgment, that's also not correct. So you have to understand when you need to do a biopsy.
Yes.
Okay, next, last case.
We'll quickly run through this case. 72-year-old man, intermittent bleeding per rectum, abdominal distension and colicky abdominal pain since 1 month, unintentional weight loss, constipation, and lower abdominal pain since 5 days. Abdomen is soft, but there's mild tenderness in the left iliac fossa on deep palpation. A digital rectal examination is actually normal in him. Sigmoidoscopy shows a UPG approximately 15 centimeters from the anal verge with significant narrowing, and the scope could not be passed beyond. The biopsy is adenocarcinoma. His carcinoembryonic antigen is 10.2. USG done for pain abdomen was suggestive of a space-occupying lesion in the liver as well, with no ascites. How would you proceed with this?
Dr. Bharat, I think you can just tell off all the investigations. We just have time to discuss.
PET CT done showed a hypermetabolic heterogeneously enhancing lesion in the sigmoid extending up to the upper rectum with few colic lymph nodes. There was also a 4 into 4.5 centimeter mass lesion in segment 7 of the liver, compressing the right hepatic vein. How would you proceed?
Yeah, just before that, is PET CT good enough to classify the liver lesion?
No, sir.
To find
MRI of the abdomen is better to characterize the liver lesions. PET CT is more for the extrahepatic disease if there's any uptake.
Right, next move on.
He is again microsatellite stable. He is symptomatic primary with an oligometastatic liver disease. How would you proceed?
Sir, symptomatic primary and oligometastatic liver disease, we'll have to address the primary first, either in the form of diversion or resection if possible. And then I would like to follow with neoadjuvant chemotherapy and then surgery for the liver.
Any role of synchronous resection for this patient?
Synchronous, he is 72-year-old elderly patient and symptomatic primary. Uh, I'm not sure how much he can tolerate synchronous resection in this.
Anything else? You said diversion and resection. Any other option?
Stenting can be done in a elderly patient, 72-year-old in this patient, but it's
What are
still
the risk?
reserved.
What are the risk? Yeah, what are the risks of stenting?
There's risk of perforation, there's the risk of bleeding, uh, risk of
But
migration of the
those
stent.
are all
Very
present, but
less.
very small.
Yes,
But
very
more
small
important thing of
percentages.
stenting here would be what? You're not
To
planning to restrict
bridge,
the tumor.
yes, to as it acts as a bridging therapy between if we can optimize the patient and take for synchronous resection, it acts as a bridge for that.
Suppose you're not planning for resection immediately.
Yes.
What is the
Next.
problem with stenting?
If you're not planning for
See,
resection.
Yeah, immediate resection. Stent can slip. If the tumor responds to chemotherapy, the stent can slip out.
it will migrate and
Right?
come out.
Yes.
So what are the how would you manage this patient?
Yes, so first either for this surgery for the primary, either in the form of diversion or resection if possible, and then systemic chemotherapy followed by surgery for the liver.
Why would you want to do surgery for the primary?
Symptomatic primary, he has subacute
And relieve the
intestinal
symptom by
obstruction
a
or
diversion or stenting.
yes,
Much taken care of. What are the advantage and disadvantage of doing this surgery first? And Dr. Snigdha, would you differ from your colleague or would you plan some other management?
Uh, I would prefer to do a diversion ostomy first to relieve the symptoms and then go for systemic therapies,
What system therapy?
chemotherapy. Then go for chemotherapy before
Why would you want
uh,
to do that?
uh, giving chemotherapy in a synchronous disease has shown to have DFS benefits. Uh,
You should understand that there is no one right answer
yes,
how to manage this patient. And
yes,
options are possible.
yes.
So many host of factors are involved in taking that. If you are not wrong, either move the primary, then give systemic therapy, then take care of the secondary. Or you can temporarily relieve the symptoms that the patient has got, give systemic therapy, then plan for surgery for the primary as a stage procedure for the secondary or as a simultaneous.
Just to be a devil's advocate, if this patient didn't have any symptoms and he tolerated colonoscopy well, then what would your line of management be?
so again multiple
Asymptomatic
options.
primary with oligometastatic liver disease.
Yes, so there are again two options: synchronous resection followed by adjuvant chemotherapy or neoadjuvant chemotherapy followed by synchronous resection or liver first and then rectum later. There are 3, 4 options available in such a scenario.
Why would you do liver first in this? You normally do liver first.
Liver first is for when there was an unresectable liver disease and we have given systemic chemotherapy, then the liver first is preferred. But in this patient, synchronous resection can also be done because it's a solitary oligometastatic liver lesion.
What is the problem in synchronous resection in this patient?
Age is a factor, so
Generally,
72.
synchronous resection is preferred in right-sided cancers or left-sided or rectal cancers.
I'm not sure the site.
Does it have anything to do with the infection or the ease of surgery? Not that
Yes,
it
sir.
cannot be done in left-sided, but the possibility of infections would be more
Is more
synchronous
for a
with the
left
left-sided.
side. Yes.
Is there any emerging evidence to say that the liver first approach may be inferior?
No, I've seen that liver met survey has shown liver first approach is preferred, is a better option, but I don't know any evidence for
There's a
any
recent
inferior.
study.
Yeah, there's been a recent publication in Journal of Colorectal Surgeon where it shows it's inferior
Yes.
compared to primary colorectal resection. But then there are other papers which can contradict as well. So, the option is open. For this particular patient, this patient had a low anterior resection with ileostomy, and then so you will give chemotherapy, and then you'll go for liver resection later on. How many segments can you take off when you're doing a synchronous resection?
So up to 3 is considered acceptable.
It's usually 1 to 2, not more than that. But if it's non-anatomical resection, you can take off a lot more than that.
Yes.
Okay.
Apart from resection, any other modalities to treat the liver metastasis?
Yes, sir. There is, we can treat it with either thermal ablation, that is radio frequency, or microwave ablation. But
What are the
resection is
advantages?
preferred.
Which one would you prefer, RFA or microwave? And why?
Over RFA and microwave ablation, sir. Both are equally acceptable, sir, oncologically. And I think
Problem with
RFA has more lateral spread to the neurovascular structures compared to microwave.
microwave has got
Microwave
more
ablation
lateral.
is the preferred modality these days.
Okay.
Potential
Microwave has got
radiologists prefer that over.
the heat sink effect is less with
Yes.
microwave.
Dr.
What is
Stikner,
other
you
option?
had said you would give chemotherapy. Suppose the liver metastasis is what would you do?
Sir, yes, there is
Dr. Stikner.
entity called, yeah.
Ideally, I would like to mark the lesion before start of neoadjuvant therapy, so by coiling the liver lesion and then start systemic therapy, sir.
Is it necessary?
Uh, no,
Maybe
it's
it may be necessary for small tumors less than 2
yes, sir.
centimeter, but not
Yes.
always.
Okay. Yes.
If it disappears, what will you do?
If there's no residual lesion on the liver, then I would not resect the liver.
Will not
What
resect.
was the problem with that?
What is the chance of hybrid tumor cell if you don't resect? 40 to
Right.
50%. So there is high chance of local recurrence if you don't resect.
Yes.
If the patient doesn't want surgery at all, is there any other option apart from RFA, microwave? You mentioned all that. Is there any other option nowadays? Can your radiotherapy colleagues help? Elderly man, he doesn't want operation, he's sick otherwise. Can your radiotherapy colleague help with any other technology?
SBRT.
SBRT can also help to target the liver.
Okay. Can we just move on? I think there are a couple of more slides. And next. So yeah, what we do?
Now
No, I
that's
think we have covered all this, I think.
specific thing because he was obstructed and we went ahead with resection. He also needs a completion colonoscopy before planning for the treatment. These are the images. Can you just tell us where exactly the lesion is? Here?
There are multiple lesions.
Anything that is seen
Lesions
on
are
this,
there, but
on this.
which lesion is malignant, metastatic?
Yes.
What are the other lesions?
The other
Which
lesions
one?
look like simple appendixes. The one
Where is the
malignant,
metastasis there?
Which segment is that? The one which
yes,
is suspicious.
yes.
The one which is suspicious, which segment is it in the liver?
On the right side in the segment,
Segment.
Segment 7.
There can be
Segment
only 4.
Segment
yes,
6.
Segment
that
7
is
is
6.
abutting the right hepatic vein, so it has to be.
Yes, sir.
So there is a 3x4 lesion that is present in the segment 7 of the liver, abutting the right hepatic vein. How would you proceed? I think we discussed this. He underwent a
No, I think, yeah.
metastatic.
So he already underwent
Metastatic.
Yeah.
So non-anatomical resections are also oncologically acceptable in colorectal liver mets. And how would you follow up this patient? Anything
As
different
again,
compared to the previous patient? Or would it be the same?
As
this is
he's
stage 4.
metastatic to begin, follow-up would be more frequent. Cross-sectional imaging would be more frequent for this patient. So,
Apart from chemotherapy, is there any other agent that you would be thinking about for this patient?
he is
Targeted therapy.
yes.
Pardon? Was that?
Targeted therapy is coming, but it's only in unresectable cases rather than resectable. This is a resectable lesion.
Bevacizumab, and they are
Yes.
mutated, KRAS. What molecular markers would you do anyway for colorectal liver mets or any metastasis in colorectal cancer?
Sir, RAS testing, that is KRAS and NRAS and BRAF mutation testing, sir.
What are the chances of this tumor coming back in the liver once again after resection? Is it a complete solution that you have done resection, given chemotherapy, done the primary resection, and the patient will be not having any more liver mets, or
No, sir, there's chance of local recurrence.
not only local, but recurrence in the
Liver.
other parts of the liver is as high as 30-40%.
Yes.
Okay.
Thank you, Dr. Rasagnan. Thank you, Dr. Snigdha.
Thank you, sir.
Thank you. Thank you.
Thank you, moderator. Thank you, examiners. Thank you, examinees. Sharat sir, are you there?
Yeah.
Sharat sir.
So, yeah, I think it was one of the best cases which we have seen in the master classes since a long time. I must thank Bharat Shankar. It was a very well prepared case. One of the most standard case presentations which has come in the IASO master classes. Perfect template, as we can say, as something like a boilerplate standard. Congratulations, Bharat, and thank you for this perfect case presentations. Rasagna and Snigdha, I think you have answered flawlessly. The whole presentation has gone very well, and your answers were prompt, in tune with the answers which were expected, which the examiners were expecting. It was something like a musical, and it was very smooth flowing today. I think that is probably because you were expecting the answers and very very well prepared for this thing. That is what we expected from you people. Dr. Arnab sir, Dr. Gupta is the main brain behind the master classes, which is available to all the students on behalf of the Indian Association of Surgical Oncology. He's a passionate academic. I know him as a close and my senior when we started the master classes together. Very well trained oncosurgeon, and as we know him, very strong with his basics and his academics. It comes from his training from England. I mean, very nice of him to be here with us. Dr. Ramakrishna, again, one of my close friends, and I have been a fan of Dr. Ramakrishna since long time. He is a perfect examiner today. He will be giving the expert talk. And thank you, Ramakrishna, for sparing your time to be with us. So now I request Srijan to continue with the proceedings again.
Thank you, sir. Just a reminder to all the attendees, IASO MidCon at Puri is happening next month. The abstract submission has been extended to 15 January. Many awards are there to be won. We request all the participants to kindly participate in the IASO MidCon. And the QR code is here. You can just use your camera, take a screenshot, and submit abstracts and have a good time at the ISO MidCon. Now I invite Dr. Ramakrishnan to kindly share his screen, and we are all ears for the expert talk in the current management of strategies of neoadjuvant therapy for rectal cancer. Over to you, sir.
Thank you. My screen visible?
Not full screen yet. Okay.
Now?
Yeah.
So thanks to the IASO academic section for asking me to talk today. I thought I would, in light of the many confusing neoadjuvant treatments that are currently available, thought I would talk about how to navigate the neoadjuvant treatment landscape in locally advanced rectal cancer. Before I go any further, I'll just give you a case scenario, and then we will see how we can deal with this. I would want all of you to just mark your responses in the chat box. This is a situation where a 50-year-old male with rectal cancer, on MRI it is T3B N1M0. All the information that you have, please mark how you would treat this patient. You operate upfront on this patient, you give neoadjuvant chemotherapy, you give neoadjuvant long course chemoradiation or short course radiation alone, or would you offer total neoadjuvant treatment? I'll go ahead with my talk. Meanwhile, as and when you see fit, you can give your answers. If you look at the latest version of the NCCN guidelines, in a microsatellite stable rectal cancer or a locally advanced T3 tumor, they advocate total neoadjuvant therapy. Either radiation followed by consolidation chemo or induction chemo followed by radiation, or only neoadjuvant chemo followed by reassessment. They only say that radiation alone may be considered in select cases, that is a patient who is not candidate for an intensive therapy. On the other hand, if the patient is deficient MMR, they advocate neoadjuvant immunotherapy. So are they the only options, or can we do anything else? First, you need to understand what is the rationale for giving neoadjuvant treatment in rectal cancer. In a so-called locally advanced rectal cancer, which is even now continued to be defined as T3, T4 with any nodal status or any T stage with a positive nodal status. In this situation, you give neoadjuvant treatment to reduce this complexity of the surgery, to improve the oncological outcomes, increase the possibility of sphincter preservation and the possibility of organ conversion. Whereas in an early rectal cancer, there still may be a role for neoadjuvant treatment if the idea is to increase the possibility of sphincter preservation or try for a organ preservation. The aim of treatment in rectal cancer traditionally has been to reduce the local recurrence, reduce the distant metastasis, and improve the overall survival. This is the same as for any other cancer that you would treat. Before the 1980s, where surgery alone used to be the treatment of choice for rectal cancer, used to see a high proportion of local recurrence up to the tune of 40%. Because of this, 3 decades between 1980s and 2010, focus was on reducing local recurrence, and by the introduction of total mesorectal excision and the use of neoadjuvant radiation, the local recurrence could be brought down to less than 10%. How does radiation help in rectal cancer? What do we know about the role of radiation? We know that neoadjuvant short course radiation can reduce the local recurrence by almost 50% compared to only TME. We also know that neoadjuvant long course radiation almost halves the local recurrence rates when compared to adjuvant long course chemoradiation. And while the long course radiation causes better staging, there is a higher risk of acute radiation toxicity. But when compared to short course radiation, the oncological outcomes are pretty much the same, except probably in the case of distal rectal tumors, where the oncological outcomes are considered better with long course. Stockholm 3 trial also told us that short course radiation with a delay an oncologically safe alternative to either short course radiation with immediate surgery or with long course radiation. And it also has the advantage of having less post-op complications. But what we must also remember is that neoadjuvant radiation is a local treatment and it does not improve survival if good quality surgery. So before 2020, how was rectal cancer being managed? In the United States, as per the NCCN guidelines, all patients with a T3, T4 or a node positive rectal cancer used to receive neoadjuvant chemotherapy. Whereas in Europe, it was a more risk stratified approach where based on the MRI, the patients were classified into low risk, intermediate risk, or high risk, so-called good, bad, or the ugly tumors. And based on this, patients were offered either TME alone or preoperative chemoradiation followed by TME or preoperative short course radiation followed by TME. Although this brought down the local recurrence rates to less than 10%, we're still grappling with the problem of a high incidence of distant metastasis, nearly to the tune of 32. Now, why does this happen in a conventional neoadjuvant therapy where you give radiation followed by TME followed by adjuvant chemotherapy? We are still not sure whether chemotherapy given in the adjuvant setting actually has any benefit. There is a possibility of delayed initiation of systemic therapy because you are losing time by giving radiation and then operating on the patient. Patient has to subsequently recover from surgery and become fit for adjuvant therapy, by which time almost 4 to 5 months would have elapsed. And during this time, there is no effective treatment for any micrometastasis which may have been present. Also, because of the problems related with the radiation and surgery, at least 70% of patients actually complete the planned adjuvant. And it is because of this that the concept of total neoadjuvant treatment started emerging. So post 2010, we saw trials that were looking at intensifying the treatment, especially the neoadjuvant treatment in rectal cancer, the so-called total neoadjuvant therapy, where the radiation as well as chemotherapy is given before surgery. Be either radiation followed by consolidation chemotherapy, or it could be induction chemotherapy followed by radiation. In some of these trials, after surgery, further adjuvant chemotherapy was also considered. Now, I'm not going to go into details of the various total neoadjuvant treatment trials. I'm sure all of you would be aware of it, but just to summarize, you have the Rapido and the Stella trials, which looked at short course radiation followed by consolidation. You have the Prodigy 23 trial where induction chemotherapy with FOLFIRINOX followed by chemoradiation was looked at. And you have the OPERA trial, which is, I wouldn't say is actually total neoadjuvant treatment because the number of chemotherapy cycles given preoperatively was less when compared to the standard of care. Now, what do we know from these trials? We know that the PCR rates have increased with total neoadjuvant treatment when compared to standard of care, that is chemoradiation. There's not much of a difference in the R0 resection rate, but the primary endpoint in most of these trials was the disease-related treatment failure or the disease-free survival, which these trials showed that there is a less incidence of distant metastasis when TNT was given. So TNT improves the disease-free survival and reduces the incidence of distant treatment-related failure. Stella trial and as well as the Prodigy trial also showed a slight improvement in the overall survival. And we also know from the long-term results of the Rapido trial that there might be an increased incidence of local recurrence with short course radiation and consolidation. But we must also remember that these are all very high-risk patients. Probable explanation is that the quality of surgery after TNT using short course radiation and consolidation chemo was probably not as good as when only chemoradiation was. So I already told you the traditional aims of treatment in locally advanced rectal cancer. These were mostly oncologist-driven aims. Of course, the patient also benefited, but at the back of the mind of the oncologist was cure. However, contemporary aims of treatment in locally advanced rectal cancer have moved beyond just achieving cure, because these are now dominated by the patient. We need to avoid over-treating the patient in order to reduce the toxicity of treatment and also to improve the quality of life of the patient, and as well as to reduce the long-term complications of it. You are all aware of, and you would have seen, toxicity of the various modalities of treatment in rectal cancer. I don't need to tell a forum of surgeons what are the complications that can happen after surgery. There's a whole list of that. Radiation is also not without complications, amplifies all the surgical complications. It has its own toxicity on the bladder, on the rectum. It amplifies the low anterior resection syndrome. It can cause second malignancies, so on and so forth. Even chemotherapy is not without toxicity, besides acute toxicity, which can sometimes be life-threatening, and which can also lead to abandonment of treatment, can also cause a very distressing toxicity, that is peripheral neuropathy. So given that we have so much of toxicity with the multimodality treatment, which is currently the standard of care, is there any way that we can reduce the toxicity by avoiding one or more of these aspects of multimodality treatment? So can surgery be avoided in locally advanced rectal cancer? The OPERA trial, even though the primary endpoint was not to look at organ preservation, it did show that when compared, the two arms were compared, the disease-free survival was not different between a consolidation chemotherapy or induction chemotherapy when given as part of total neoadjuvant treatment. However, what it showed was there was a high rate of organ preservation. At 5 years, more than 50% of patients who received consolidation chemotherapy were TME free. They did not have to undergo surgery, compared to almost 40% in patients who received induction chemotherapy. But one thing that you must all remember is that organ preservation strategy must be intentional and not incidental. Intentional meaning you need to plan at the beginning of treatment itself that your goal of treatment is to achieve complete response. The possibility of achieving a complete clinical response is, of course, in early stage tumors, especially T2, node negative tumors, tumors where there are no EMVI, where the MRF is not involved, tumors less than 4 centimeters long, and which are non-circumferential. Now, is TNT the only way to achieve organ preservation? Can we remove the component of chemotherapy from the neoadjuvant treatment and still look at organ preservation? This was a French trial called the OPERA trial, very similar in sound to the OPERA trial. But this trial looked at only specified group of patients, that is low or mid rectal tumors, early stage T3 tumors, less than 5 centimeters in size and less than half the circumference. These patients were randomized to either the standard chemoradiation with external brachytherapy boost, or a combination of both external beam radiation as well as a contact X-ray boost using the Papillon technique. What they found, remember, no consolidation or induction chemotherapy or even adjuvant chemotherapy was used. And the contact X-ray boost was almost 90 gray over 4 weeks in 3 fractions. This trial again showed a very high rate of organ preservation. Your organ preservation rate was 9% in the control arm versus 81% in the experimental arm. And if in smaller size tumors, the experimental arm, it was almost as high as 97%. So it is possible to even avoid chemotherapy and with radiation alone achieve organ preservation. Now, is radiation also necessary? Can we avoid radiation? Because as I showed you, radiation has its own side effects. This was the PROSPECT trial, which was conducted at in the many centers in the United States, where they looked at, again, early tumors, T2N1 or T3N0 N1 tumors, but they had to be eligible for a sphincter preserving surgery. and they had to be at least 3 millimeters away from the radial margin, meaning they had to be RF free. These patients were randomized to either standard long course radiation followed by TME or chemotherapy with 6 cycles of FOLFOX. Even to this, response assessment was done, and in those patients who had a good response, which they labeled as more than 20%, the patients directly went on to TME without neoadjuvant radiation. Response was less than 20%, they went on to receive long course radiation. So the disease-free survival was not really different in the patients who received only chemotherapy or patients who had received no radiation. What they concluded is that preoperative chemotherapy with selective chemoradiation is non-inferior to routine chemoradiation. See, the local recurrence rates, even when radiation was avoided, is less than 2%, and is no different from when radiation was given in this select group of tumors. There was no difference in the 5-year overall survival rate, and nearly 91% of patients who received the neoadjuvant chemotherapy were able to avoid preoperative radiation. One thing that you must keep in mind is that the patients in this, only 14% of patients had a low rectal tumor. Most of the patients had a mid or upper rectal tumor. Now, is there any way that we can even avoid chemotherapy as well as radiation? We're all familiar with the Mercury trial, in which this was not a randomized trial, it was just a prospective study in which patients who were determined to have a good prognosis tumor on the MRI, meaning they were free, the MRF was free, they were T3A or T3B or even less, and they had no EMVI, and the intersphincteric plane was clear of tumor. These patients, they were subjected to primary surgery. And what they found that even in these patients where radiation was avoided and direct surgery was performed, the local recurrence rate was less than 2%. The 5-year overall survival and disease-free survival was pretty good, almost 80% 5-year disease-free survival in this group. So we can conclude from this that surgery alone in this group of good prognosis stage 3 rectal cancer can also result in good oncological outcomes. The next question would be, is there any way we can avoid all these things? Yes, recent evidence is emerging that in a select group of patients who are mismatch repair deficient or MSI high, the use of immunotherapy successfully avoided radiation or chemotherapy, leading to a complete response in a very small group with limited follow-up. So we are still awaiting long-term results from this study before we can conclusively say that we can avoid radiation and chemotherapy or even surgery with only immunotherapy. So the 4 key elements in rectal cancer management these days are the circumferential resection margin, the MRI, the MDT. We know that involvement of circumferential resection margin can predict local recurrence as well as the overall survival. We know that MRI accurately predicts the involvement of the circumferential margin and also identifies good prognosis stage 3 tumors. And it has also been shown that assessment of the CRM status by the MRI is even superior to the TNM staging. We want to assess the risk of local recurrence and survival. And I've also told you earlier that MRI-based MDT discussions has been shown to reduce the CRM positive rates. So what is the 4th component? What is emerging these days is the patient preference. Why is this important? Because there is often a contrast between what the oncologist thinks is good for the patient, what the patient prefers, and what he wants out of it. Just to give an example, this was a study regarding the preference of patient towards surgical options for rectal cancer. And here it was found that more than 60% of patients would give up a mean of 34% of their lifespan just to avoid a permanent stone. Would also be willing to give up chemoradiation, even if it meant that to reduce their lifespan by almost 20%. And not surprisingly, these preferences frequently differ from those of physicians. What we think may be right for the patient is not always what the patient want to have. Because it is a duty of the physician to explain all the options and tell the advantages and disadvantages of each of them. But it is also important to give a ear what the patient actually. How does MRI help in identifying risk factors for recurrence? MRI features can predict pelvic recurrence, like P4B tumor, involvement of the MRF, presence of lateral pelvic node, low rectal tumors, etc. MRI features can also predict distant metastasis, presence of tumor deposits, presence of N2 disease, presence of EMVI. These are not absolute. There is a gray area in between, and some of the features that predict pelvic recurrence can also predict. But this is a rough idea for you to identify from the MRI whether this patient is at a higher risk for pelvic recurrence or distant recurrence. So how would you plan neoadjuvant treatment? One way of doing it is to work backwards. What is the final surgery that you are planning to do? This is also in conjunction with what the patient wants. Suppose the patient doesn't want surgery and you are planning to do an intentional watch and wait approach. This can be performed in, as I told you earlier, the best candidates for these are T2 or early T3 tumors, node negative tumors without EMVI, not involving the mesorectal fascia, non-circumferential, and less than 4 centimeters. These tumors, you could opt to give TNT or, as per the OPERA trial, external beam radiation with contact X-ray. Now, suppose you want to do a local excision. This is also possible in T1 to T3 tumors without any nodal involvement, but they need to be less than 40% of the circumference of the rectal lumen and within 8 centimeters. These patients give just long course radiation or even neoadjuvant chemotherapy. Evidence for that comes from the Neo trial, in which only chemotherapy was given, followed by local. Suppose none of this is possible and patient needs to undergo TME or sometimes even a beyond TME surgery, you can still consider no neoadjuvant treatment if it is an early tumor, like I had mentioned earlier, or if it is an advanced tumor, you need to consider some form of neoadjuvant radiation, which may even include a total neoadjuvant. What are the indications for total neoadjuvant treatment? There is no real data to support induction chemotherapy followed by short course RT. But short course RT followed by radiation can be considered in tumors that are locally symptomatic, but at the same time high risk for distant metastasis. As an induction chemotherapy followed by consolidation radiation can be considered in patients who are locally asymptomatic, but again at high risk for metastasis. Whereas long course radiation followed by consolidation chemotherapy could be considered in patients who want to preserve their organ or who are at a higher risk for pelvic recurrence, where you need good tumor regression. So now let us come to the example that I stated first. Now consider this. I just mentioned it is a T3B-N1. There are different scenarios where it could be T3B-N1. This is a near circumferential mid-rectal growth, 5 to 9 centimeters above the anorectal junction, but below the peritoneal reflection. MRI-wise T3B-N1, EMVI negative, MRF is not involved, no lateral pelvic nodes. I'll just quickly run through the images. So in this patient, you could do upfront surgery, especially if it is in the mid or upper rectum. The MRF is not involved without other high-risk features like EMVI or lateral pelvic nodes. The Mercury trial has shown that in such patients, if you operate straight, the local recurrence rate would be only around 3 to 4%. And by giving neoadjuvant treatment, you're not going to improve the local recurrence or survival. Therefore, in these patients, there is no risk of undertreatment. Advantages are that you can avoid the toxicity of neoadjuvant radiation, you have better functional outcomes, shorter overall treatment time, and thereby you can even reduce the cost of treatment. The caveat, you need high quality MRI reporting, you need a very good TME surgery, and you need a standardized pathological examination of the same patient. If he were in the United States, probably would have received neoadjuvant chemotherapy, especially if they were mid-upper rectal tumors, all the conditions that satisfy the inclusion criteria for the prospect trial. Again, the local recurrence is less than 2%. You can avoid radiation in 90% of these patients. Better functional outcomes. Will you prefer neoadjuvant chemotherapy over upfront surgery? And otherwise, neoadjuvant radiation is indicated. The tumor is more than T3B, but however, the MRF is negative. And probably consider it for low rectal T3 tumors, although the proportion of such patients represented in the prospect trial was less. You would also consider it if there were other risk factors for distant recurrence like EMVI or tumor deposits, where you would prefer to give neoadjuvant chemotherapy rather than operate on this patient. Now consider another patient, again with a T3B N1 tumor, but this is a low rectal tumor. The lower border 3 centimeters above the anal verge. Again, there is no pelvic nodes. EMVI is negative. Have a look at this MRI. These are the axial sections. So this is a low rectal T3B tube. So in this patient, is it okay to give neoadjuvant chemoradiation? Yes, if the patient is at a high risk for local recurrence, low rectal tumors are generally considered high risk for local recurrence. Or if it were a T3C or T3D tumor, or if the MRF was involved, or if there were lateral pelvic nodes. Again, in such situation, these patients would have benefited from neoadjuvant chemo. At the same time, the patient preference is for organ preservation. In a low or mid-rectal tumor, T3A or B, less than 5 centimeters, less than 50% circumference, according to the OPERA trial results, chemoradiation with a contact X-ray boost is a possible option again for this. When would you consider total neoadjuvant therapy? When the risk for both local recurrence as well as distant metastasis is high. For example, in low mid-rectal tumors with presence of EMVI or tumor deposits, or even MRF involvement, or the presence of lateral pelvic nodes. In these patients, the Rapido trial included exactly these sort of patients, or even the Prodigy trial where induction chemotherapy with long course radiation. However, the Prodigy did not really specify how many of these patients had all these individual risk factors. Again, if these patients were low or mid rectum and the patient is very highly desirous of an organ preservation, but does not satisfy the OPERA criteria where you can avoid chemotherapy, patients could be treated by long course radiation and consolidation chemotherapy as per the trial. An intent of achieving complete clinical response and avoiding. So this is one such patient in the lower rectum who has received total neoadjuvant treatment and has had a complete response to total neoadjuvant. This patient could be spared morbidity of surgery. So how has rectal cancer evolved over the years? As you all know, till 1980s, surgery was the only treatment available for rectal cancer. Subsequently, radiation was introduced. First, it was adjuvant radiation, and then subsequently, it was neoadjuvant radiation, followed by surgery, and then adjuvant chemotherapy. And then post 2020, we saw the emergence of total neoadjuvant treatment and then followed by surgery. Then we also saw that surgery could be avoided in patients after total neoadjuvant treatment if they had a complete clinical response. Subsequently, recently, the results of various trials have shown that we can avoid radiation, give neoadjuvant chemotherapy, and operate if there is a good response, and only in the poor responders we can offer radiation. Opera trial also showed that chemotherapy can be avoided, when surgery can be avoided with a contact X-ray boost after or before chemoradiation. And probably in the future, with the advent of immunotherapy, we can avoid all the other traditional forms of treatment. There is a clear divide where initially the treatment used to be multimodal and more toxic. Slowly, we are coming into an era where treatment is becoming unimodal or bimodal and less toxic. So we are in an era of de-escalation of treatment for rectal cancer. So what I would like you to take home from this is that neoadjuvant treatment for rectal cancer is not a one-size-fits-all approach. Patients must be discussed in a multidisciplinary tumor board for optimal care. TNT, that is total neoadjuvant treatment, can improve the disease-free survival, reduce the distant metastasis, and also improve the organ preservation. There are specific indications for TNT. Not all locally advanced rectal cancers require TMT. That is something that you must keep in mind. Indications for TNT are tumors with a high risk of local recurrence, like clinically T3, T4 disease, MRF positivity, or lateral pelvic floor involvement, or patients who are at a high risk of distant metastasis because of a higher nodal stage like N2, MDI, or tumor deposits. TNT can also be considered if organ preservation is the of treatment. Currently, patient preferences, the quality of life of the patient, avoiding treatment-related toxicity, all this play a major role in choosing the for rectal cancer. But are they more important than oncological goals? Probably not. Oncological goals still must be kept in mind before trying to de-escalate and for rectal cancer. De-escalation approach, avoiding either one or more of surgery or radiation or chemotherapy, can be considered to reduce the treatment-related toxicity as long as it doesn't compromise on the long term. Thank you.
Thank you so much, sir. I think one of the shortcomings of the webinar format is that we don't get to really applaud after a talk. And I think this was such a complex topic, and the way that you have taught us all the different modalities and how they are heading in a direction where we'll have to be really conversant in all the evidences, and then talk to the patient as well, and take their preferences into consideration before we decide. It was a wonderful talk, sir. Thank you so much for that. I request Dr. Bharat and Dr. Arnab Gupta to join us for the Q&A session as well, along with Dr. Ramakrishnan. We have 4 questions left from the chat. I would begin with the first one. And the question was in the Indian context, and the question was, is the MSI testing at diagnosis before treatment really required for all patients? Arnab sir, could we start with you?
You're muted.
Yeah. Well, although the NCCN guideline talks about MSI testing, even at diagnosis, but in Indian setting, even in our center, we do IHC, MMR testing, so that should be okay. But then, especially for advanced disease, MSI testing has to be done because it can make a lot of difference. In the era of de-escalation, especially, I think MSI is going to be more relevant. But in Indian setting, to be honest, in our hospital, we do just IHC, MMR testing to start with, and later on, we consider MSI testing down the line.
Anything to add, Dr. Bharat or Dr. Ramakrishnan?
I think in the metastatic setting, it is absolutely essential because more number of people are willing to take in immunotherapy. It's about 5 to 10% what we see the possibility of MSI being positive. But in the neoadjuvant operable setting, like Sir said, probably the real situation is real world evidence is much less applicable in the Indian context. But I think it's important to do it in order to see what lies ahead in the future.
Uh, I'll go to the second question, and I think this question is more about intraoperative localization of lesions, tattooing, marking, that sort of thing. And the question was if there's a borderline palpable lesion or a second lesion or a small polyp, what method of identification are the experts using at their center to localize, and secondly, to avoid a positive margin when there's a doubt? Ram sir, could we start with you?
I didn't really understand that question, but if my understanding is correct, the answer to that would be there are two options. One, you could preoperatively do a colonoscopy and tattoo the lesion so that you would be able to identify it. Now, this doesn't work in tumors that are below the peritoneal reflection. The other option would be to do an intraoperative colonoscopy and then assess the lower limit of the tumor and then decide where you are going to take the lower cut.
Which kind of, yeah, that's the correct, sir. What ink do you use to tattoo the lesions when you do that?
Methylene blue.
Methylene blue. Dr. Bharat and Arnab sir, any comments from you?
Yeah, just a word of caution because I also do a lot of therapeutic colonoscopy. So if you have to tattoo the lesion, you have to be very careful that you don't inject all the way because all we'll see when you go inside, especially laparoscopically, it'll be all blue. So it has to be, in the right plane, is usually submucosal plane. That's number one. Number two, you can't do it on the, if you are doing intracolonoscopy, uh, you know, sometimes we do it, you have to clamp the bowel, proximal to the lesion so that the whole bowel doesn't get distended. So that has to be second lesson. Third is, if you're operating on a patient who had neoadjuvant treatment, you have to go by the original margin. So even if the tumor has regressed proximally, you should not go by the new margin because we had issues where the microscopy margin came positive because obviously we underestimate the lesion at that time. So that's also very important. And another trick which I've learned from one of my colleagues, you can actually put the hemostatic clip, which is used for controlling the bleeding endoscopically, as a marker distally, which you can pick up on the C arm. So that's also useful. So that's something we have tried and is really beneficial.
Sir, any role of any fluorescence guidance, few hours to few days in advance, injections are reported?
I've heard, but I've not used it.
Right.
We do have an ICG, but we have not used it for that purpose.
Right, sir. So we'll move on to the next question. Some centers have the practice of doing a prophylactic oophorectomy, especially in perimenopausal or postmenopausal women, especially after long course radiation have been given. Is there, do the experts follow the same at their centers, or it's an unnecessary step?
We do not do that unless the patient is at a high risk of peritoneal recurrence because of other reasons. Tumor or above the peritoneal reflection, P4A disease, or if the patient already had or limited disease, probably in those situations, peritoneal would be performed. But more importantly, I think the question is not whether after NACT oophorectomy should be done or not. The question is before NACT, preserving the fertility, something for that situation, laparoscopic mobilization of the ovaries can be considered. Patients who are desirous of maintaining.
Right. Mm-hmm. Sir, Arnab sir.
No, I'm not very sure why this issue was raised. Is that an issue? I mean, doing an oophorectomy, because this is not something we discuss about. I'm trying to learn from you.
No, sir. The question was in the light of rectal cancer also having certain associations where you could have a second ovarian cancer in a patient who have good survival. And if you have already radiated it, the toxic dose for ovary is 12 grays. There is, I won't say a standard practice, but there's an option discussed with patients beforehand whether they would opt for a oophorectomy setting. Obviously, I would agree with Ram sir that if it's a young patient, the best thing to do is do a ovarian transposition beforehand. I think the question was in that light. The last question is any role of ctDNA which is emerging in the management of colorectal cancer? We'll start with Dr. Bharat.
Yeah, like it's again part of the NCCN guidelines as well to try and do, but there's no qualitative data to back our evidence at this point of time. But in centers where it is available, definitely it is, the trends might indicate some prognostic indices. So it's good to do it, but I don't think I would change my treatment choices based upon the levels of ctDNA. However, probably more intense surveillance if you are suspecting a trends which are rising.
Ram sir?
Currently, we don't practice this, and the evidence is pretty sketchy at the moment. For follow-up, probably it could have a role in detection of recurrence even before it appears even radiologically or clinically. But I'm not sure of the current utility of this in our Indian scenario.
I think most of the molecular biology scientists are actually proposing this for most of the cancers, especially for advanced cancer. But then I think it is going to be a while before it becomes a standard of care, and it may not be applicable in Indian setting at all.
So that's all from the Q&A. I'd like to thank the examiners for explaining all these minor points in detail. This brings us to the conclusion of the today's webinar. Can I invite Dr. Rudra Acharya to kindly give his comments and deliver the vote of thanks?
Good evening. I think it was a wonderful presentation by the students, by the moderator and our experts, Arnab sir and Ramkrishna. And I think Ramkrishna presentation gave the latest in the management of C rectum, because the patient's point of view is always missed. I think this was very specifically emphasized by Rama. And I think with changing the changing treatment modality from 2010 to till now, so many trials, so many things new coming, and at last we are ending with no surgery, wait and watch. So everything was very well updated by Rama, and I think it is one of the best webinars. This recording will stay in the YouTube, and all the students can benefit again who have missed. I think I thank from the IASO, the whole team involved from Indo-American, and all our experts and students for doing wonderfully. I think, thank you very much. We will be hoping for a operative session on the same topic after 15 days. So look to the future. Thank you very much.
Thank you very much, sir. I would again like to remind all of you, we are having a session on the 21st, which is 2 weeks from now. We'll be learning on the actual surgical steps in rectal cancer surgery. We will be circulating the link shortly. Thank you all, the examiners, the guests, and dear examinees as well. Thank you for joining us this evening. We conclude this session now with your permission. Good evening to all.
Thank you, Srijan and Jeva. Thank you very much.